sort of an abbreviated version of what's already in your packet in terms of the statistical data. Going right into it, if you have that, show that first slide, I want to emphasize to you that I am the medical examiner and see the end point of this, but it really represents a very, very small part of the problem. The bigger problem is actually what they're seeing out of the emergency rooms and the clinics. If you take it to the next slide, you'll see that a small percentage of a large number is still a large number. So when you're talking 1 or 2% of 113 million emergency room visits being related to the misuse of drugs, that represents a substantial problem nationwide. And the drugs in particular, if you go to the next slide, are primarily opiates. Certainly about a third of the cases are psychotropic drugs, and another third of the cases are anxiolytics. But actually, over 40%, and that doesn't add up to 100, but you can see the percentages on the handout there, are opiates, pain medications, and that's what seems to be driving the train nationally as well as here in New Hampshire. If you look at drug deaths in the United States, you can see the primacy of opiates or pain-relieving narcotics in terms of driving that train. And the next slide shows among the opiates the role that methadone is playing and has been playing for several years. If we look specifically at New Hampshire, you can see that over the last decade, we have had, or the last 5 years, we've had a 450% increase in drug deaths. And while not all the 2011 data has been crunched yet, I can tell you as I stand here today, 2011 represents the first year in New Hampshire history wherein we will have achieved 200 drug deaths over the course of a single year in this small state. If you look at the agents that are driving our train, they are very much the same. They're primarily opiates as a class and methadone in specific. By age, it is the group that is ostensibly the most productive members of the New Hampshire society. They're people between 40 and 60. The kids that get started as teenagers and 20-somethings become the eventual, quote, chronic pain diverting, doctor shopper, pill mill sort of folks that end up overdosing on their opiate medications sometime between 40 and 60. It comes as no surprise that men outnumber women in this, just about everything in the high-risk category. Men outnumber women, just something about the Y chromosome, hair on the ears, remotes, and high-risk behavior. If you look at manner of death, the vast majority of these are not intended outcomes. These are accidental deaths, either because of recreational use or the increasing need for more and more opiate to achieve the same effects. Looking specifically at our drug breakout, you can see that opiates as a class are responsible for over 2/3 of our deaths, and if you look at the breakout of the opiates, methadone leads the way. The next table shows over the last several years the top 10 appearing drugs on death certificate. Now when I say drug deaths, these are deaths that are due specifically to drugs. This is not traffic and or homicide and. These are specifically drug deaths. And for the last several years running, and I can guarantee for 2011, the number one drug is methadone. The second is oxycodone, and that in recent years supplanted cocaine as our number 2 drug. Let's look at national statistics again and look at the states with the highest increases of methadone deaths over a 5-year period. And you can see 2 New England states are in that group, and New Hampshire falls in at number 5. Now, there's a clinical conundrum associated with that. As Dr. O'Connell mentioned, there are lots of people with genuine pain from genuine pathology, and methadone, in that respect, is an excellent drug when administered properly, when monitored properly, and when used properly. But obviously, if any one of those 3 things are out of kilter, there's a problem. And treating even outside a pain clinic or a pain management center, like Dr. O'Connell does, think of the care providers that are out in emergency rooms that are faced with the, oh, my aching back or my knee kind of complaint, and trying to measure whether or not they should prescribe for that individual. If you look at the sources of this, it should lay to rest any myths that the methadone problem is emanating from narcotic treatment programs or opiate treatment rehab programs. That's not where it's coming from. It's not coming from the liquids that are dispensed at opiate treatment programs. It's coming from the pills that are prescribed for pain. As a matter of fact, during the same period of time where there was a large increase in prescription writing for methadone, in New Hampshire, the increase was 563%, nearly 6 times an increase in the rate of writing for methadone. Now, there are a multitude of reasons for that, and we could get at it in the Q&A if you want, but there's no time to get into that now. When methadone is used for pain management, it's supposed to be the 5 and the 10 milligram pills. The 40 milligram sort of wafer types of these things that you break apart were never meant for pain control or for use for prescription for pain control. Those were for opiate treatment programs, yet they were consistently being prescribed for pain control, and as you can see on the next chart, New Hampshire was very, very high among the states that saw the distribution of these 40 milligram diskettes, not to opiate treatment programs, but to pharmacies from where they were being dispensed on the basis of prescriptions written by care providers for pain. If you look at the next slide, as I mentioned to you, what I'm seeing in terms of fatalities is a mere drop in the bucket to what the care providers are seeing out in the community. And it starts, obviously, in the teen years. If you look at teen medication abuse, at least in its present guise, and it shifts from generation to generation, but prescription medications are misused twice as often as marijuana, 5 times more common than cocaine, and 60 times more commonly than heroin. The most recent data from the Youth Risk Behavior Survey in New Hampshire, 2009, indicated that 1 in 5 New Hampshire youth in this survey, this is a survey of, I believe it's 12 to 18, or maybe it's 14 to 18. 1 in 5 report taking 1 or more prescription drugs without a prescription in 2009. Well, why does that matter? If you look at these 2 pie graphs, it's busy, but it's important. And what it tells us is, the plus sign means you have misused an illicit drug at any time in your youth. The predictor for that is that only about a quarter of the time will you go on to not use anything else. But those other areas of the graph indicate that you will go on, your percentage risk, statistically speaking, of going on to misuse 1, 2, 3, or more prescription drugs or illicit agents, as opposed to the person represented by the negative sign there. This is the kid who never did it, and they stand a much greater chance of not going on to abusing drugs. Now, it's obviously intuitive, and everybody says yes. What's the point? Well, the point is that 1 in 5 are currently falling on the plus side of that graph. So why is that? If you ask the kids themselves, 2/3 of them, or nearly 2/3, say it's just so daggone easy to get a hold of. Mom's medicine chest, mom's purse, grandma's house. Grandma doesn't throw anything away. The Tea and Toast girls keep everything they've ever been prescribed. And yeah, she's got the Percocet that she got for her, her surgery 5 years ago, and they're still sitting there in the medicine chest. They're easy to get, and they are everywhere. And furthermore, if you look on the next slide, there is no perceived risk. These are pharmaceutical-grade drugs. They're quality controlled. The federal government's involved. What could be safer? It's magical thinking, I know, and it seems ridiculous to the people in this room. But kids are convinced these are not dangerous because they're legal and they're commercially available. 20% of them don't even think that prescription pain medicines are addictive. Well, heroin's addictive. Cocaine's addictive. My mom's pills, those are not addictive. If you go to this last slide, or this next slide, and you're comparing traffic deaths to drug deaths, this is an obscenity. We predicted in our office, I believe, as early as 2004, that at the rate we were going to exceed traffic deaths in terms of drug deaths. That got some attention, not all of it positive. But it came to pass, and the split is growing wider. If we had another public safety or public health issue of the same magnitude, people would be they'd be marching with pitchforks and torches for us to get a solution to the problem. The noise would be heard all the way up to Representative Bradley's office if you had a 450% increase in drownings or asthma deaths. Well, we're finally starting to hear that. The solutions are the things that you're going to be discussing today. And there's a broad variety of possible solutions. You heard Dr. O'Connell mention the possibility of prescription drug monitoring, and I'm very keen on that. And that doesn't happen without community coalitions working together. If you can, obviously you've heard some of the names of those coalitions right in this area. And if we actually address the issue of oversight of prescribing, it's been referenced here that a majority of the states have this, and it's been proven that states surrounded by other states with prescription drug monitoring programs bear the brunt of diversion. If you look at this map, we're surrounded by states that have it. There are arguments against it, if you showed that last slide, but I think that those arguments can largely be countered by rational, demonstrably proven, evidence-based solutions.